organized by CAHN and its partners. So CAHN is the Caribbean and African Health Network, and the partners are BHI Black Health Initiative. We've got our Croydon BME Forum, Enfield Caribbean Association, Rafa International Development Agency, and the Royal Assembly Redeemed Christian Church of God in Sheffield. So thanks to all our partners, and thanks to everyone who works tirelessly behind the scenes to make these programs a success. And most importantly, thanks to you, wherever you're joining us from this Saturday morning, sparing your special minutes and an hour and a bit to join us to make this program a success. My name is Dr. Diana Asante, your regular host. I'm a GP and the Deputy Lead for Primary Care for CAHN. And as always, it's a pleasure to be hosting you. We are live on Zoom, as you obviously know, because some of you are joining us on Zoom. We're live on Facebook and YouTube, and we've also got engagements on Twitter and Instagram. Now, today's topic is a very interesting one. I know that we've had sessions this month already on breast cancer and prostate cancer. And today we're going to be talking about cervical cancer, a very important topic because it's one of those cancers that is relevant to everyone. And I know you'll be thinking, oh, I might be a man. How does this relate to me? But it's important to everyone because it's one of those cancers that a lot younger people can get. So even in the UK, we have a cervical screening program that starts from as early as 25, because the evidence is there that screening, even from as young as that age, will make a massive impact. So if a sister or a friend or a mother or an auntie or a family member is affected by this, it affects you as a husband or as a brother or as a son or as a father. So it is an important topic for every single one of us. And I entreat all of us to engage with today's discussion. We've got a very important personality with us today. Her name is Dr. Joanna Abiola, or rightly so, Miss Joanna Abiola, because she's a surgeon, a gynecologist, an obstetrician. She's a consultant in her field, and she's also got a special interest in cervical cancers. She also does some leadership work. She's married with children. She wears many hats. A very, very busy lady who's taken time out of her busy schedule to be with us this morning. And it's my absolute pleasure to welcome you, Miss or Dr. Joanna Abiola, to this CATHIP Health Hour. And you can tell us a bit more about yourself and take us through the session. The topic for today is cervical screening, cervical cancer and screening, prevention, prevention, prevention. Over to you, Dr. Joanna Abiola. Thank you.
Thank you very much, Dr. Diana. It was lovely to have that wonderful introduction, and greetings to everybody who has taken time to join today. It's a pleasure to see everyone engaged and interested in this extremely important topic. Yes, I am a consultant in obstetrics and gynecology, and I also have a special interest in gynecological cancers. So those are cancers affecting the female reproductive system. So that goes from cervical cancers, vulval cancers, ovarian cancers, and cancers of the womb. I also do obstetrics, so that involves care of the woman in labor, care of the pregnant woman, and care of the woman following having her child. So, Dr. Diana, are you happy for me to progress with my slides?
Yes, please, fire away. And please, our audience, do remember to pop your questions as we go along. We will have a Q&A session at the end, as we normally do. And Dr. Abiola will be able to answer all your questions. Thank you. Please carry on, Joanna. Thank you.
Lovely, thank you. So yes, my topic today is cervical cancer and screening. So indeed, it is extremely important for us all to be aware about cervical cancer and the screening for it. The most important thing and the take-home message today is to do all you can to prevent it, and do all you can within your power to be in control, because this is something that we have a small amount of control over. And today I would like to inform everyone and make sure people are aware of what they can do. So, service your cervix. I guess the question is, when did you last service your cervix? The cervical screening program is open to all, and all women should be invited for a smear every 3 years. So today I will go through cervical screening program. I will talk about the results from your cervical smear. I will talk about the risks for cervical cancer. I will also touch on the signs and symptoms of cervical cancer and how cervical cancer is managed. I will just put a warning out there that we do have a few images that may be sensitive for some people or younger people. So I would advise any little eyes to be away, or anyone who's a bit sensitive just to be aware that we have a few images that may be a little bit cringeworthy for some people. We'll see. So this is back to biology 101, essentially. So we've got the womb, you have your cervix here. I'm not sure if you can see my cursor. So this is the cervix, which is the neck of the womb. The uterus here, where babies grow, your fallopian tubes, and your ovaries. So I'm going to be talking about diseases affecting the cervix. As a gynecologist, I regularly look at diseases affecting the vulva, which is the skin here, the vagina, the cervix, the uterus, and the ovaries. So why do we screen? And this isn't just cervical cancer. We screen for lots of different conditions. And it's important that we look at the whole population and we see if there are things that we can do to reduce the risk of cancers or other diseases. So we screen for other conditions such as breast cancer and bowel cancer.
Yeah, it's just the one number, got it.
Cervical cancer is another cancer that we screen for. So I will go on to talk about why that's done and how we do it. So cervical screening starts from a woman when she's 25 years old. However, we shouldn't be alarmed when you get your invitation letter at 24 and a half. This is in order for the woman to prepare and be ready for her first screen at 25. So young woman receives a letter at 24 and a half, and then she gets her appointment, and you must make sure you attend. So every person who has a cervix between 25 and 65 will be having a smear test. Now, between the ages of 25 and 50, you have smear tests every 3 years. When you are 50, you will then go on to have smear tests every 5 years. Now, this is for everyone who is running through the cervical smear and the cervical screening program normally. As I go on in my presentation, I will be talking about the reasons why you deviate from the screening program or why your own personal screening program will be adjusted. But most women will be having 3 yearly smears until they're 50, then 5 yearly until you're 65. The smear test is a really simple test. I appreciate it is uncomfortable, but it's a simple test where we take samples from the lining of the womb with a little brush. As you can see in this image below to the right, this is what your cervix looks like. So when you are having your smear test, your cervix will look like this after it's been examined. And a little brush is used to take a sample of cells from your cervix here. Remember, this is the neck of the womb. We do this to look for pre-cancers on the cervix. So the cervical screening program does not look for cancer, it looks for pre-cancer or early cancers so that they can be treated appropriately. The benefit of the cervical screening program in the UK and around the world is that it reduces the number of cases of cervical cancer. The reason being is that if you look for pre-cancers and you treat pre-cancers, then you reduce the risk of cancers actually occurring further down the line. Hence the need to make sure you attend your smear tests, get your smear done, and make sure you eliminate pre-cancer. There's a few tips by Joe's Trust. So Joe's Trust is a national cervical cancer charity, and you can find lots of information and leaflets online. So first of all, if you find it uncomfortable to have your smears, you can ask for a longer appointment. You can go with somebody that you trust. You can ask for a smaller speculum, and I'll go on and show you some pieces of equipment that we use when you're having your smear test. You can ask for a smaller one that might be a bit more comfortable. Another tip that women are encouraged to do is you wear a skirt or dress, and it makes it a lot easier and a lot more comfortable when you have to undress to prepare for the examination. And make sure that you ask questions. So don't just go to have your test and just have it done and go. You ask questions along the way, make sure you're informed, make sure your concerns are being addressed. So this is a speculum. It looks worse than it actually is. So the tips of the speculum here, these are the blades. So these are what gets inserted in the vagina. Usually there'll be lots of gel as well, so it's comfortable, and essentially inserts into the vagina, opens up so we can see the cervix in between. This side here is the handle and the screws, and these sit outside, and these are used by the operator, so usually the doctor or the nurse, just to help to insert the speculum inside. So you've had your smear test and you potentially get an abnormal result. And just to encourage everyone, it's only about 5% of people who go for a smear test that will get an abnormal result. So the first good news to remember is that 95% of people who go for the smear will be told, everything's fine, see you in 3 years. It's only 5% of people who will then have an abnormal smear test and be invited for another test in colposcopy. And I'll go on to talk about colposcopy soon. So this abnormality, or this group of people with abnormal smears, it's a very small group, 5%. Even if you have an abnormal smear, the risk of cancer is, again, extremely very small. So we've got 5% of people with abnormal smear. Maybe only 1% of those 5% will have cancer. So you can see the figures are extremely, extremely small. So most women with abnormal smears don't have cancer. Most women with abnormal smears have a precancerous treatable condition. So you have 3 or 4 different results from your smear. You have a normal result, see you later in 3 years. Inadequate result, see you and do the smear again in 3 months. Or you have an adequate result, which means that they've been able to do the smear adequately, and it will come back with HPV positive, which is a virus which causes precancerous diseases on the cervix. And it will also talk about dyskaryosis. So those are 2 things I will describe a bit more now. HPV is a virus which can lead to precancer on the cervix, and dyskaryosis is essentially a word which means how abnormal are the cells on the cervix. HPV is the virus which causes abnormal changes on the cervix. So HPV and what are the cells doing? So you can have mild, moderate, or severe dyskaryosis. Essentially, it means, are there mild changes, moderate, or severe changes on your cells of the cervix? Either way, all women with HPV positive and any form of dyskaryosis will be invited to colposcopy clinic. Before I go on and talk about colposcopy clinic, I'm going to touch on HPV because it's really important, especially for those of us who have young girls and boys, because there's now a HPV vaccination program. So there are over 100 types of HPV viruses, and they can cause different types of cancer in the body. So most people will have had HPV at some point in their lives, but you don't have any symptoms when you have HPV. Most people clear it spontaneously, and it's usually caused by close sexual contact. So most adults in their life will have had HPV and they're fine, and you clear it and everything's okay. In cervical cancers, we do see HPV present, and in some women, extremely rare numbers of women, you have HPV that has not cleared and continues to cause abnormalities on the cervix. So the good news is that since September 2008, there's a national immunization program. So it's essentially a program that provides the HPV vaccine to children ages 12 to 13 And this essentially offers 10 years of protection against HPV. And this is offered in 2 rounds. So you have your first round in year 8, and then 6 to 24 months after, you have your second round. The thing with the vaccine is that it only protects against 70% of the HPV types. As I said, that there are over 150 types of HPV viruses, and this vaccine is called Gardasil 9, and it protects against 99 of the high-risk HPV viruses. And these viruses are associated with pre-cancer of the cervix. And this pre-cancer is also known as CIN, which is cervical intraepithelial neoplasia. Essentially, it means pre-cancer caused by HPV, and this vaccine protects against 70% of the types of HPV. Obviously, it can be quite controversial because these children are young, and obviously it's going to bring forth some questions for concerned parents, such as, my child is too young to have these conversations, or is this virus going to harm my child? Will this child be at risk if they don't have the vaccine? Will this mean that my child will engage in unsafe sex in the future, as a teenager perhaps? And also, does this mean that your child may not attend for smears in the future because they feel that they've been protected? I'll go on to talk about these later, but these are some questions that I hope we'll be able to discuss later during the question and answer session. So, colposcopy. This is the setup of a colposcopy clinic. So this is where I usually have clinics probably every 2 weeks, and I see about 8 women in my colposcopy clinic. So women who are referred here have had an abnormal smear. So this is the 5% group. They've had an abnormal smear and they come. First thing, you keep your appointment. You must attend. So another piece of good news, most women coming to colposcopy will be discharged. The purpose of colposcopy is to look at your cervix under a microscope. That's all. You've had your smear test, you've got the sample of cells on a brush. Now it's more of an in-depth look at your cervix under a microscope. Some women are offered treatment because if pre-cancer is suspected, we can treat there and then. And that's it. It's done. So I'm actually going to go back 1 second. So just to highlight a few pieces of equipment, just so it's not intimidating if anybody is invited. So this is a big stacker at the back. Got 2 screens here. So usually I'll be looking at the screen on the right. I invite my patient to look at the screen on the left if they choose to. This is the couch, the examination couch, which provides the option to change the height of the couch. And these are the stirrups, or women will know about these stirrups. So these are where the patient's legs will go, and bottom goes towards the end of the couch here. This is where the colposcopist sits, and this is the colposcope, which is the microscope in which we look at the cervix. So this is the colposcope here. A beam of light shines down, we look at the cervix here, and this is the speculum I showed you earlier. So the beam of light shines down, the cervix pops into view. We usually apply some special dyes on the cervix, and we can visualize the cervix and see if there are any worries about pre-cancer. Again, we are worried about pre-cancer, and if we are worried, then we can either take a little biopsy or a larger biopsy based on our worry. When you come to colposcopy, don't be alarmed if you have a few people in clinic. You'll have a support worker, a nurse, and a colposcopist. So the colposcopist, essentially, colp means cervix, scopist is essentially using a scope, a camera, to have a look. So it's somebody who's specially trained to look at the cervix. And it can be a doctor like myself, or it can be a specialist nurse who has undergone extra training to be able to do these procedures. One thing I will mention, it's really important to make sure that you are not rushed straight to the examination couch. When you come to colposcopy, ask them to discuss your results from your smear test. There is no need being rushed to have an examination until your smear results have been discussed. Make sure you know why you've been referred and that they know also. Make sure they can see your results and make sure that they have discussed the examination you are going to have and consented you for it. So these are just some things to be aware of and conscious of at your appointment. This is just a cartoon illustration really, but we have what looks like a normal part of the cervix. This is called low-grade CIN, which is essentially early precancer, and it's progressing until cancer. I'm just going to go back again. So what can you expect? You can expect someone to look down a microscope and look at your cervix and look for any of these changes. It takes about 5 to 7 minutes. It's not a long time. It is a little bit uncomfortable. Most of the time, your cervix will be inspected and that's all. However, in some cases, if we do suspect precancer, like these quadrants here, or if indeed we suspect cancer, we can offer a larger biopsy. For example, if I look down and I'm worried that there's this low-grade CIN or low-grade early cancer, I can take a tiny biopsy, maybe from about here. And that's a tiny little pinch. You don't need anesthetic because it really is a small, tiny pinch, and that's done, and you had a biopsy. If I'm worried about more severe precancer or even cancer, I will do what's called a LETS treatment, which is a loop of the cervix here with anesthetic, and that is to remove any suspected pre-cancer. If you do have a treatment or a biopsy, then sometimes you can feel some cramps, a little bit of vaginal spotting, and some blood-stained discharge. You will get a letter with your results within 2 to 4 weeks from after your appointment. Your result will either say the biopsy was inadequate, and in some cases you may need to come back for repeat biopsy. The result may show that you've just got the HPV virus and that's all, and it may show precancer. And these are the precancers here. So CIN1, that's cervical intraepithelial neoplasia. Another phrase for that is precancer, and that's stage 1, or CIN stage 2 to 3. And these are the more significant precancers, and in these cases, you will be offered treatment. And like I said, the treatment is usually in the form of an excision of the precancerous tissue on the cervix under local anesthetic, and that is sufficient for your treatment. So a bit more scientific here for the doctors or the scientists or the people who are interested. So we'll just go through it again and I'll summarize it. The cervix is looked at from below. This is the cervix, the neck of the womb. HPV comes along at some point in your life. Most of the time you clear it. However, in some women, it persists. And this can take about 5 to 20 years. It persists and keeps causing these changes on the cells. CIN1, CIN2, CIN3. Again, it takes decades of persistent HPV infection, and usually in this group of women, decades of not attending your smears, decades of not going to colposcopy, decades of not returning for your follow-up appointments, and unfortunately, cancer can then occur. This is rare. This is rare. It only happens when you potentially don't attend for smears and follow-ups at colposcopy. It's understandable that women are worried after they've had a biopsy or treatment in the colposcopy clinic. You may worry, has the treatment removed all the cells? Do I need further treatment? Will I get cancer? Those are all natural and understandable concerns. You may also worry, is the HPV virus still present? Have they taken all of the pre-cancer away? And that's fine. There are usually 3 outcomes from colposcopy after you've had your results. You either return back to your original routine recall because your treatment has been sufficient. Sometimes, if we've had a look at your cervix under the microscope and we think that it is very low grade or very low grade precancer, we will invite you for more frequent smears. So like I said at the beginning, you have 3 yearly smears. However, if we think you have a very low grade precancer, and that's like the CAHN1, you'll come back for yearly smears, and usually that's with your GP. In these cases, it's just that the HPV virus is taking a little bit longer to clear, and that's fine, and that just means more regular smears. Some women may need further treatment. I'll touch on colposcopy and future pregnancies very briefly, and people may have questions about this later. So when I'm in colposcopy and I'm removing tissue from a cervix that I'm worried about precancer, I've also got to consider the age of the woman and whether she's had children or not. The cervix is important for supporting a pregnancy. So if I'm removing tissue, I've got to be aware that the amount of tissue I remove isn't going to compromise a future pregnancy. If a woman does have a treatment that removes a larger amount of tissue, there is a smaller increase in the chance of preterm delivery. And obviously that in itself has risks for mum and for baby, particularly infections, stay in the neonatal unit, and developmental delay for children. So that needs to be a detailed discussion and a balance of the risk of cervical cancer and the risk of preterm delivery. However, we can manage this. When I work in obstetrics, there are ways that we can assess the cervix in pregnancy and check the length of it. And in extreme situations, if the cervix is too short to support a pregnancy, we can put a stitch there which holds the cervix and holds the pregnancy and hopefully reduces the risk of preterm delivery. So we will go on to discuss this later, but obviously there are some barriers for women attending for their smears. There are some fears, and there are undoubtedly going to be some myths that people hold on to, people believe. And hopefully when we do our questions and answers, we can go through these and I can hopefully dispel some of these. The cervical screening story in the UK is really a success story. There's no room for complacency. The most important thing is to make sure you attend your smear appointments and attend colposcopy clinic if you are invited. I'm going to touch on cervical cancer. The reason why I'm not spending most of my time on cervical cancer is because it's rare. And we only get to this point if the points I've discussed before haven't been addressed, i.e. if you haven't attended for your smear, if you haven't attended colposcopy, if you haven't followed up with your results. And unfortunately, when these happen, it can get to this point when women are diagnosed with cervical cancer. Sorry for the extreme picture, but this is, yes, a cervix with cervical cancer. So it is rare that I would examine a patient and see this, extremely rare. But because this is my special interest, I see maybe two or three cases a month I see within my work, within cancer and gynecological cancer. It is uncommon. It's extremely uncommon for me to see this. But like we've said before, it's linked with HPV virus that has persisted and not been checked, strong risk with smoking. There are links with low socioeconomic status And that goes across the breadth of many health conditions. So if a woman is disadvantaged for any reason and potentially can't attend for appointments, or doesn't understand the information that has been given to her, or doesn't have the money to be able to get to her hospital or GP practice to have her smear test, doesn't have the support. Maybe she has 3 children at home and can't attend. And I regularly see women like this who have not been able to afford or arrange childcare to attend for their appointments. And unfortunately, we do see these in women with cervical cancer. They've not been listened to, perhaps, or they have had concerns and they've not gone to see a nurse or a doctor. We also see cervical cancer in women who've had biopsies or smears that have been abnormal and not followed up. Like I said, the number one reason is failure to attend your smear appointments or colposcopy appointments. Some women with cervical cancer don't have any symptoms at all. Most women have a form of abnormal bleeding. Some women have painful intercourse or find that they have abnormal lumps in their groin. Some women do present with lower back pain. And after these symptoms have been assessed and reviewed, you are then examined by someone like myself, a gynecologist, and you are sent to clinic for a biopsy. Again, this is outside of screening. This is a woman who has suspected cervical cancer. The treatments for these cancers are essentially going to be discussed within a multidisciplinary team because it's complicated. You have to see the type of cancer. Has it spread? And this is usually detected with an MRI scan. Sometimes some women have a PET CT scan, which is essentially a CT scan looking at lymph nodes in the abdomen and the pelvis to see if there is spread of the cancer to the lymph nodes. We also do chest X-rays to look at the chest to see if there's any spread of disease in the chest too. With women with early cervical cancer, usually stage 1, they can be treated with minor surgery in a colposcopy clinic. This is for very, very early cervical cancer. When it gets more advanced, then women are referred to a specialist unit for chemotherapy, usually with radiotherapy or surgery, and that is for advanced disease. It is very, very rare to get cervical cancer if you have been attending for your smears. Again, it is very, very rare to get cervical cancer if you have been attending for your smears. And I do hope I've been able to highlight the importance of attending for your smears and colposcopy clinic appointments if they arise. Thank you so much for your time. A smear lasts 5 minutes. The impact of cervical cancer lasts a lifetime. Thank you.
Thank you. Thank you so much, Dr. Abiola. What a wonderful presentation. What a simplified, broken down to our level presentation that was, with all the pictures that actually made us understand it better and brought it home. You know, things like even seeing what a speculum looks like for some people is really helpful. Just having an idea of what the cervix looks like, knowing where you're taking samples from. So you've really simplified that to the level of hopefully the sort of least scientific minded person in the audience today. And that was very important. And as Dr. Abiola said, it is very rare to get cervical cancer if you have been conscientiously attending your screening. So please, I'm sure that one of our take-home messages today is do attend your smears when you're called forth for it. And if you don't hear from them and you know, oh, I should be having a smear now, do chase up and find out. I have lots of patients who go, oh, actually, I can't remember when I last had a smear. I might be coming up to one. And sometimes it's just useful to check. Sometimes people have moved GP surgeries, their details have changed. Sometimes people have changed addresses, they've not updated the system. And there could be all sorts of things. So please do engage with the cervical screening program. Thank you so much for that, Doc. That was really wonderful. I've really enjoyed it. And also just highlighting the fact that it's such a success story. And I think because we're so privileged in the UK, we probably don't realize how successful these screening programs are, that it can be such a rare cancer because you're actively looking out for it and you're actively screening the general population for it. And another message which our doctor gave us today is the fact that if you've got symptoms, then you must see your clinician or your GP. The screening is purely for people who are in the general population. So with screening, we're trying to catch people who have no symptoms. We're trying to catch things early. We're trying to prevent people getting these cancerous cells in the first place. If you are getting abnormal bleeding, or you've got pain after sex, or you've got uncomfortable pelvic pain, don't say, oh, my screening is in 6 months' time, so I've got a screening coming up. Please go and see your doctor about it. Thank you. Right, so we are having some questions come through in the chat box, and we'll zoom straight into the Q&A session. For those of you who've joined us, this is the CATHIP Health Hour session brought to you by CAHN and its partners and Black Health Initiative, Croydon BME Forum, Enfield Caribbean Association, RAF International Development, BHI, Royal Assembly, Redeemed Church of God. Thank you for joining us once again. So Dr. Abiola, someone is saying this lady is probably joining us from Germany. Her name is Ruth Eichendorf. I think I'm hopefully got that name right. And she's saying that I've been having pap smears even after the age of 60, and I've been having yearly pap smears, she says. Why might this be the case? Why might she be having pap smears every year after the age of 60, please? Thank you.
So thanks, Ruth. So first of all, welcome, hello from Germany. I don't really know the cervical screening program in Germany. So first of all, it may be that the screening program differs in Germany compared to the UK. Within the UK, we have 5 yearly smears up to the age of 65. So number one, the program may be different in Germany. Number two, it may be that you've had abnormal smears in the past and you've been taken off the routine cervical screening pathway. So like I said at the beginning, the 3 yearly and 5 yearly is for women who are having normal smears and have never had an abnormal smear. If you have an abnormal smear, you're no longer on the routine pathway. You have a specialized pathway based on your results. So I would speak to your GP and ask them to show you your previous cervical smear results and speak to your colposcopist, and they should be able to answer the reason why you're on yearly smears. And it could be that this goes on till 65 and then that's it, but there'll be a reason why you are on yearly smears specifically.
Okay. Thanks for that, Ruth. I hope that helps, and I hope you
attend your yearly smears.
Yes, exactly. Thank you. Now, Dr. Abiola, you mentioned LETS treatment along the line. You mentioned LETS, and some of us might not know exactly what LETS stands for. People might be wondering, what is LETS? What actually happens when you do LETS? Can you delve into that a little bit more for us? Thank you.
Certainly. Apologies, I didn't expand on that in the presentation. So LETS treatment essentially stands for loop excision of the transformation zone. And Dr. Joanna has helpfully written LLETZ. So historically it was LLETZ, which was large loop excision of the transformation zone. But because it was causing significant anxiety and distress for people, it's been changed to loop excision. Essentially, it's a heated wire loop that is used on the cervix under anesthetic to remove suspected precancerous disease on the cervix. The reason it's called a loop excision of the transformation zone is that you are removing the area where cervical cancers originate from, and that's the transformation zone. So it's a full treatment, and it is the full treatment for precancer on the cervix, and it's sometimes a treatment for early stage cervical cancer. So if you are invited for a treatment, please don't worry. It may be that they suspect precancer and they are offering you a one-stop treatment. And that's really important to go and attend and have it done. It is done under local anesthetic. Some women, I do the procedure in theatre. I did one on Thursday for a woman who was 62. I think she'd had abnormal smears, and she had a procedure in theatre just because when you are a bit older, the vaginal tissues are drier, it's a bit more uncomfortable. So she wanted hers done under general anaesthetic. So I listed for her to be done on my theatre list. So I did hers. But most women will have it done in a colposcopy clinic with local anaesthetic.
Thank you. Thanks for clarifying and expatiating on that. And just as you've mentioned about having a procedure under a general for certain patients, suitable patients, obviously, it just brings to mind the fact that there are some patients who are extremely anxious, aren't there, about having their smears done. And specifically, while we're talking about the fact that we want to increase access for people, and we want the sort of compliance, if you like, or people sort of engaging with the process to be increased as well. How do we reach slightly disadvantaged people? So I'm talking here about people who might have learning disabilities, who cannot fully understand what you're talking about to adequately consent, or for instance, people who might have, autistic spectrum disorders, or just something that really unsettles them, and they're not going to lie down for you to, gently insert your speculum and do what you need to do. And I've actually had a patient in the past who was so terrified after her first smear, just because she's got her own other medical conditions, and she's not a patient. She had learning disabilities and autism and this and that and the other. How easy is it to get the smear done, or even further procedures done under GA? Because I know that some of these things are not as straightforward, but how easy is it for you to say to the gynecologist, can you please do it for this patient? And what would you be looking at?
Absolutely, that's a really important question. And I do have a few referrals in the past for women who are in that situation. First of all, it's really important to have an advocate. And I believe that advocate could be a family member, a friend, or a support worker, or a carer, for example, who will come with that woman to the appointment and advocate for them and just say, they're really going to struggle to have this examination. Can we list them for under anaesthetic? And there are different forms of anaesthetic. You can have a general anaesthetic, or you can have a procedure done with sedation. So you're not asleep, but the anaesthetist could give you stronger medication to make you a bit more comfortable and a bit more relaxed and enable the examination or procedure to be done. So most gynecologists will accept a referral if a GP, for example, has requested a patient to have it done under general anaesthetic. And usually this occurs when a GP has documented that they've actually tried, they've had a discussion with the patient and they've actually tried to do the smear test and it's not been possible. And that request shouldn't be refused. I'm a strong believer in not denying requests like this, because ultimately we are trying to reduce and detect cervical cancer. So I'm not going to deny someone an anaesthetic if it could potentially save their life.
Thank you for that. And so for anyone here or anyone out there who's concerned about, it's not the norm that everyone is going to jump on the table, have a GA to have their smear done, but there will be cases where people genuinely would be better served that way. And if that is a concern, please discuss it with your doctor, and as colleagues, we can liaise with each other so that everyone is able to access this very important service. Thank you for that, Joanna. So just a follow on with Ruth from Germany. She's just added on to say, I've never had a colposcopy. Should I have one? So I think she's adding on to what she said previously about her initial question.
So absolutely. So colposcopy is not for everybody. Colposcopy is when you've had an abnormal smear. So it's when you've had an abnormal smear test, which has shown the HPV virus and has also shown dyskaryosis. So it's also important to remember that you can have the HPV virus persistently and the cells have no abnormalities. And in that case, you will have a yearly smear rather than 3 yearly. So just because you have HPV, it doesn't mean you automatically go to colposcopy. The reason we see women in colposcopy is if the HPV virus has caused abnormal changes on the cervix. And that's when we need to have a look at the cervix in more detail. So Ruth, no, you don't need to go to colposcopy. Colposcopy is for women who have had abnormal smear results.
Thank you. Ruth, hopefully that helps again. And there's another caller who's asking, So someone is asking why male patients are getting cervical cancer vaccine. So there is some confusion about why that's
so just to review that. So the vaccine isn't against cervical cancer, it's a HPV vaccine. The vaccine protects people, male and female, from HPV-related infections. And I'm just going to see if I can just try and get back to that slide, because it goes through I think there are about 7 types. Let me try and share my slide again. There are about 7 types of HPV infections. So can everyone see that? Hopefully, yeah. So as you can see here, HPV virus can cause oral cancers, penile cancers, vaginal, vulval, anal, and cervical. So the virus causes multiple types of pre-cancer and cancer. So we give people the vaccine ages 12 and 13 to prevent pre-cancers in all these regions. So all school children in year 8 are offered the vaccine. It is your decision if you are going to allow your child to have this. It's ultimately your decision, and it's discussion between yourself and your child and the school, obviously.
Thank you. What's your biased opinion on that?
I'm very grateful that my children are 2 and 5 at the moment, but it's a sensitive issue. First of all, the information is there. Whether you choose to allow your child to have the HPV vaccine, I think that's the age in which children have already had discussions from a sex ed perspective. So I'm not sure about when this starts in school, but I suspect it probably starts between the ages of 9 and 11. Slowly children will be informed about sexual education, and it's really important, sexual health and education for children. And by age 12 and 13, they probably, some girls have probably started their periods by then. So having a discussion about a virus that could cause harm in the future, and we are going to offer you the chance to have a vaccine to protect against a virus that could cause harm. I don't think that's a difficult discussion to have with a 13-year-old. I don't think that's technically difficult to have with a 13-year-old. It is sensitive, it is difficult for parents to have that. There is support available within schools, and your GP or health visitors can help with that. But I suspect it is very challenging, and I'm very grateful that I've got probably another 8 years before I have to have those conversations.
It's coming.
I know.
Very fast. Yes. No, sorry, I did put you on the spot there, but you're absolutely right. It's important that we have these discussions, isn't it? And something that a friend always says, she says, if you don't start having these discussions with your kids, someone else will have it with them and they will do it wrongly. So do take control of what you want them to know, how you want them to know it, in the context of the values that you hold dear. And whatever your religious values are. But yeah, kids these days know a lot more than we did when we were young. So yeah, I guess that's another thing worth contemplating. But anyway, thanks for that.
Sorry, just to add a point, that the HPV, the vaccine, it's not going to mean that your child is going to become promiscuous or suddenly going to engage in activity that you do not agree with. But it means that that for the next 10 years, this child is protected from 70% of these high-risk viruses. So this will take from your child from 13 to 23. There's a point in life when we don't know what our children will be doing, and it is sad and it's difficult to think of, but at least you can do what you can while your child is under your roof at age 13 to offer a 10-year protection. So that's something to just consider.
Thank you. And the same would go for all vaccines as well, I guess, in prevention of all other events.
Absolutely.
Having those discussions and discussing those anxieties so that we can ask questions and get the answers that we need to make informed decisions.
Yeah.
Dr. Abiola Iyabo is asking, after 65 years of age, you're not likely to be invited for the smear test. Can you request one if you notice something abnormal? or just want to check you're not having a problem? So I think we've kind of answered this in a way, but I will still let you kindly answer this. So she's saying if you want to check that everything's fine or make sure there's nothing abnormal.
Yeah, I think it's a really good question. It's a really good question. So first of all, it's very rare that a woman over 65 will be diagnosed with cervical cancer. The patients I usually see with cervical cancer are in between their 30s and 50s, and because they haven't attended smear tests or haven't had follow-up for abnormal smears. Whether you should request a smear test over 65 if you have no symptoms, no. I would request an examination if you have symptoms, and that would usually start with your GP. If you've got bleeding, pain, or if you're worried, then you can request an examination. But if you don't have symptoms and you're 65, it's extremely abnormal that you would have cervical cancer. And smear tests are screening tests. They're not diagnostic tests.
Thank you. I hope that clarifies it for you. And I completely agree with Doc as well. If you do have concerns, you should be seeing your doctor to discuss them. A smear test is a screening test, not a diagnostic test. A smear test is a screening test, not a diagnostic test. If you leave here with nothing today, remember that.
Yes,
that
absolutely.
Smear test, it screens, it doesn't diagnose. So if you've got a problem that needs to be diagnosed, you need to be seeing your doctor for the appropriate diagnostic tests. Thank you for that very important question, Iabo. And lots of comments in the chat box, Joanna, about very educative session, informative session. Thank you, Dr. Abiola, and all of those. So just to let you know, getting wonderful feedback on your lovely presentation today. So another caller is saying, Akosia is saying, if I'm more than 25 years old, not married, not sexually active, is a smear test still necessary for me?
Difficult, but very good question. I've had my friends who've asked me similar questions in the past, and I would say it's tricky because, number one, it's an uncomfortable procedure if you've not been sexually active before. If you decline your smear test, you don't necessarily have to explain why, but the GP records will have this on record for you. It's extremely rare if you've not had sexual intercourse or sexual contact. It's most important to remember it's sexual contact because HPV can be transmitted from skin to skin contact. So whether it's orogenital, so mouth to the genital region, or intimate sexual intercourse, that's how people get HPV. So it's extremely rare if you've never been sexually active for you to develop either precancers or cancer on the cervix. So that being said, it's extremely rare if you were over 25 and have a smear for it to be abnormal. However, if you want to engage in an excellent public health program and want to prepare for the fact that you will be having 3 early smears anyway, then you can have it done. It's a difficult one. I would say that if you have any chronic health condition, particularly if you have a condition where your immune system is suppressed, then that's another risk factor for developing cervical cancer or precancer, or if you smoke. So I would say if you have those risk factors, I would definitely say go for your smear. If you don't have those risk factors, then the choice is yours, and that would be a choice you would have to take. And I can't really say anything more than that, I'm afraid.
Thank you. That's good enough. If someone was a virgin, let's say they'd never, yeah. So not probably in the case I was just mentioning, where, I mean, in her case, it's not entirely clear whether this person has never been active and is still not active, or whether they have been active previously and not. But let's say we have someone who has never, ever had sexual intercourse. Should they be having a smear?
You're putting me on the spot here.
I've made it even more difficult, haven't I?
All I can say is and I'm not going to give you a direct answer there, because I know what you're doing. So it is extremely rare.
That's all we can say.
To develop cervical cancer if you have never had sexual contact, and I'm leaving it at that.
Thank you. So that, I guess that's as best as you can answer it, really, isn't it? Yes, but no, thanks for the clarity. Thanks for that clarity, and thanks for that useful question as well and contribution, Akosia. So Barbara says, if one has inconclusive smear results, should there be a follow-up appointment?
So excellent question. So if you have an inconclusive smear, three things could have happened. It could be that you were on your period and you were having heavy bleeding and they couldn't get the right number of cells on your smear test. And yes, of course, repeat your smear in 3 months. It could be that you have vaginal dryness, maybe over the age of 50, more likely to get vaginal dryness, and it's difficult to get the right number of cells. So you can treat this with a vaginal estrogen or a moisturizer just to improve the chance of getting an adequate smear result. Or it could be that you have an infection that hasn't been cleared or treated, so that's important to treat that. So either your period, dryness, or infection. So treat those and then attend for another smear in 3 months' time. So definitely attend for a repeat smear.
Okay, thank you. Thanks for that as well. So people who are not sure, that's the answer for you. Do attend those repeats. And when we get the letter sent to us or the information, let's please engage, because I know that sometimes, you know, life gets in the way, doesn't it? And then you say, oh, I'm going to book my smear, and then you forget and something happens, and you know, you get another reminder. And but let's prioritize these things, because as Dr. Joanna Abiola said, you could save your life literally by going for that screening appointment or having that smear test. So please, let's engage with these. Pastor Sandra D is saying, I think in relation to the HPV vaccine, she's saying, I allowed 2 of my teenage daughters to have it. So thank you for sharing your experience, Pastor Sandra, and lovely to hear from you. Someone else is also saying, is the vaccine potent in different locations in the world?
That's a good question, because prior to 2008, America was offering the vaccine against 4 of the high-risk HPV viruses, and the UK was only offering the Gardasil vaccine against 2 of them. Now the UK is offering 9 of the HPV high-risk types. So yes, there were some areas in the world where where people were offered more protection, but the one that's been offered in the UK now is the best, and it's got 9 HPV viruses protection. So that's good.
Okay. So I guess it probably differs, I guess, depending on where you are. But for those in the UK, that you've got the one that gives you quite a lot of protection. And Lola's also sent a very important question. What are the potential side effects of giving children the said protection, i.e. the chemicals? You're not going to talk about vaccines and get away with it, are you?
That's my mum, actually, I think.
Is it? Yes.
Probably. So potential side effects. So I guess it's a side effect like any vaccine. So obviously pain, swelling on the injection site. It's very rare to get any serious, severe side effects from this, but pain, swelling, bruising on the site. But there are no documented long-term effects of having the HPV vaccine, as far as I know, and it is safe. So yes.
Thank you for that. Thanks for clarifying. I think I'm now coming probably to the one from your mum. So I think that question was from Lola Ibadan.
Yeah, that's my mum. Hi.
Is it? Okay. Because I can see Titi Lawyer Abiola, and I was assuming that person is related to you. But anyway, so
yeah,
Titi Lawyer Abiola says, great presentation, Joanna. Well done. So very proud of you, Joanna. And Ruth is saying, thank you for explaining so clearly as well. The feedback polls are being sent out, so please do complete the feedback as we go along. It helps us to improve the presentations we bring you, and also to know whether it's pitched at the right level. Right, so can I ask another question as well? So how quickly, and I know it's difficult to put, it's a piece of string question I'm going to ask you, I'm afraid. But generally, how quickly can, a detectable precancerous area or cell or lesion progress to, like end-stage cancer? So, for instance, if someone went for their smear and there was something abnormal found, and you recommended that we need to do something else, and they said, oh, no, I don't want anything doing. Potentially, how quickly are we looking at this becoming something very serious? Are we talking of months or years or decades here? Just rough. or is that really hard?
It's a complicated question because it depends on the background of the patient. So if the patient is a smoker or has other chronic health issues, and it depends on the biopsy result as well. So if you're talking CIN1, then it's different to CIN2 or 3. So CIN2 or 3, which are the more severe precancers, again, those can progress to cancer within months, if not treated, if not treated. But CIN1 could take years to progress to cancer. There are some women with CIN1 who are just conservatively managed, and even a few cases of CIN2 can be conservatively managed as well. But either way, if you've ever been diagnosed with CIN1, 2, or 3, make sure that you discuss the treatment options available for you and make sure you attend the treatment.
Thank you. So because we don't know, just really get yourself sorted, and if you've got any concerns, discuss them, because I know that for us, particularly people from ethnic minority groups, we say this each time we have these presentations, Saturday in, Saturday out, we seem to be at risk of quite a lot of things compared to our Caucasian counterparts. We've also got our own blessings, by the way, so it's not all doom and gloom, but we are also least likely to access, screening programs, to come forward, to engage with these programs. So please, the message is just, if you've got concerns, ask the right questions, seek the right help, but let's really engage with these programs. Is there any particular reason why Blacks might be at a higher risk? Is there anything like that? Are we necessarily at a higher risk?
No, not for
not really.
No,
not with cervical. We escaped this one.
That's one of them. We have escaped. Yeah, thankfully.
Okay, right. And you talked about the lifestyle measures, about other comorbidities.
So yeah, that's really important to highlight. So if you're smoking, you need to stop smoking. If you have a health issue, that means that you are immunosuppressed. Essentially, it means that you are less likely to clear the HPV virus. Make sure that you've got on top of that. So whether it's HIV, maybe you have Crohn's disease or ulcerative colitis or other conditions that mean that you're more likely to hold on to viruses rather than clearing them. Make sure you sort those out. Make sure they're optimally managed. If you are engaging in sexual contact, make sure you practice safe sex. So you use barrier contraception as well, because there is a risk with HPV in that. And those are the main things, and stay healthy. Anything to improve your general health and well-being is good, and attend your smears.
Thank you. Attend your smears. Yes. Is there anything like a best time to have a smear? So time of your cycle, for instance, or should you or not necessarily have sex before having your smear? Does it matter? Is there anything like that, or is it all fairly?
That's a really good question. So if you are being offered treatment, they'll usually do a pregnancy test to make sure that you're not in the very, very early phases of pregnancy. So I would probably say definitely make sure you're not having a heavy bleed. So if you're on your period, reschedule your smear for a week later. I would definitely advise probably no intercourse for 2 to 3 days before your smear test, just to reduce the risk of vaginal secretions interfering with the sample. And those are the only 2 things I would suggest, really, particularly for women trying for a baby. No intercourse a week before a colposcopy appointment specifically, because you may be offered treatment. If a woman has a coil, whether it's a copper coil or a Mirena coil, they may offer to remove the coil before your treatment and reinsert it after. So if you are being invited for treatment, be aware of the contraceptive methods you are being offered, and it may be that your coil is removed. So if your coil is being removed before treatment, you must make sure you've not had intercourse 7 days prior to coil removal. Again, this is to reduce the risk of unidentified, very early phase pregnancies. What we don't want to do is offer treatment to somebody who is in the luteal or the early phase of a pregnancy, and the person goes on to carry a baby and has had treatment and we didn't know, and we're not able to join our obstetric care with our gynecological care and offer the treatment to the patient.
Okay, thank you. I think we've managed to successfully go through all the questions, and hopefully we've addressed everyone's concerns. Any 3 take-home messages from you, please? 3. I'm sure you've got lots that you've told us already and lots that you'd like to emphasize. But if there are 3 things that you'd want us to go away from this session with, what would those 3 things be? I know you talked about having your smears and all
Yes.
that. I'll let you just put them into 3 nice.
Okay. Attend your smear test. That's number 1. Attend your smear test. Number 2, stay healthy. And number 3, ask questions.
Yeah. Thank you so much, Dr. Joanna Abiola, our consultant obstetrician and gynecologist with a special interest with gynecological cancers, and who's also got a hat in leadership, is also a mum, a parent, and everything else you can think of. Thank you so much for this wonderful session on cervical cancer and screening, and for going into all the details today for us. We've absolutely enjoyed it. We've thoroughly understood what you've shared with us, and hopefully someone here has been blessed, has had some information equipped that they can impact their own life or someone else's life with. And thanks for having me as well, your host, Dr. Diana Asante. I will now hand over to the team who's doing the closing. I think Sandy's doing the closing. We hand over to the team. Thank you so much,
Thank
Dr. Abiola, and thanks for everyone who's joined us today.
Thanks.
Perfect. Thank you very much, Dr. Asante, Diana. Thank you so much. And thank you very much, Dr. Abiola, as well. What can I say? You've said it all. So again, thank you very much for everyone who attended the session or who is attending the session. We really appreciate your presence today and every weekend, every Saturday. And we know and hope the session is helpful. Please do share the message around. So just some quick updates from our side. Thank you to our partners. A massive thank you to our partners, Black Health Initiative. It's a community engagement organization, and they do provide service providers and influence policies and procedures. So thank you for being here as well. And we also say a massive thank you to Croydon BME Forum. Again, another voluntary organization engaging people, building capacity and promoting equality. And another massive thanks to the Enfield Caribbean Association, again, based in Enfield, and provide services and social events for mostly Caribbean descent. Yeah, and then another massive thank you to the Royal Assembly Redeemed Christian Church of God. Thank you very much for being here. Again, engage with various community and have various based community outreach programs. A massive thanks to RAFA in Birmingham, RAFA International Development Agency. Again, you can see some information on there on the screen, so I'm not going to read everything, but you have the website there as well, and you have some contact details. So yeah, RAFA International, based in Birmingham, and they provide various support to members of the community. So next on the list, we have our next health hour on the 22nd of October. 22nd of October, we're staying on cancer. So our guest speaker will be Dr. Deji, and he'll be talking about the early warning symptoms not to be ignored. So please do invite your family members, your friends, anyone, anywhere across the globe can attend. Again, it's at the same time. If you have any question after any of this session, please do email us at event@cahn.org.uk or health@cahn.org.uk. Okay, we also have a healthy heart session every Tuesday between 6 to 7:30 p.m. where we have a nutritionist engaging with us. And the next session is on the 18th of October, where we have Dr. Robert, and again, sharing tips on healthy eating for men. So please do come along with your husbands, your sons, and encourage men to attend some of these sessions, because yeah, it's important for them as well. Okay, and we also have the same 22nd of October, we have our gala. If you've not got your ticket yet, please do go online and book a ticket or contact a team member via event@cahn.org.uk. It's also going to be the 5th anniversary, our 5th anniversary, CAHN anniversary. So it's an occasion not to miss. Let's carry the fun over. We're not just doing that for fun, but we're doing that to support the work we're engaging, the work we're doing in the community. And as you all know, we have a counseling service, we have an advocacy service that's ever, increasing. The demand is high. People from our communities need support, and we need some resources to support them. So please, it's not too late to get your tickets. Speak with your friends and family and have them to attend. And I promise you, it'll be fun. So yeah, that's all from ourselves. Have a really, really good weekend. And again, massive thank you, Dr. Abiola and Dr. Asante. Goodbye, everyone.
Thank you for inviting me.
Thank you.
Bye.
Hello there, my name is Gillian Joseph, and I want to tell you about an amazing night that I'm hosting for the Caribbean and African Health Network. They have a vision to end health inequalities for Caribbean and African people and end wider health disparities. To that end, they're holding this fundraising awards gala in Manchester at the Hilton on the 22nd of October. You can wine and dine, dance and be entertained. I'll be there. I hope to see you.
Thanks, Diana. Lovely to meet you.
Thank you.
Bye. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.